All right, our next part of the program is a panel, and I want to invite our panelists, if they would, to come on up, and then I'll actually do the introductions. We have, I think, 3 individuals coming up. Thank you. This way I get to embarrass you while you're sitting here or something, you know. All right. I would say that these panelists probably need very little introduction, but again, I hope you can sense as we're winding our way through the agenda today, the connectivity of many of the points that we tried to introduce early in the day. Next, we're going to be talking about sepsis and sepsis prevention specifically in terms of how can we prevent, how can we identify, and how can we intervene in such a way that we don't lead to the mortalities that I was describing earlier. And as we've tried to have for each of our forums, we try to have some best stories or best practices that are coming from our institutions, and today is no different. We have 2 of our member institutions who have had to address the sepsis topic in their institution. I'm sure that they would share with you that they were probably not where they initially wanted to be, but they're obviously, I hope, proud of the results they're achieving, because in looking and hearing their stories, they're doing great work, and we thought that this work is something that ought to be shared with all of us and gives us another ray of hope of how we can learn from each other and implement those practices in our institution. So today, as we talk about sepsis prevention, we're going to have presentations, and I'll come back up and we'll take questions from the floor. So I hope that you will think of your questions as you go through this and take advantage of the expertise that we have at the front table. First, from Russell Medical Center, to my immediate right, is Sarah Beth Gettys. She is Vice President of Patient Services, a position she's held since 2005. Before that, she was the hospital's Chief Nursing Officer, and earlier was Director of Quality Services. To her right is Dr. Michele Goldhagen. She is an emergency room physician and the hospital's Chief Medical Officer. She also serves as a Medical Director of the EMT program at Central Alabama Community College. And joining the 2 from Russell Medical Center is Dr. Bill Meckes, a general surgeon. Bill has been one of those that we have had front and center on our sepsis efforts here in Alabama. Been kind enough to tell his story on live and in person, and also to have been recorded. If you have not seen the information that he shared, I invite you to go out and look at that. It's my understanding, Bill, that you were actually working on a path trying to get to a level of retirement, but the passion you have on this topic has prevented his being able to do that, and he has offered to go to our member hospitals or to other audiences around the state and share this story. So I commend to you, should you need a speaker, should you need someone to share the story of taking a facility from where it was and moving it in a positive direction. Bill certainly has that capability for you. So it's my pleasure to introduce our panel. I'm going to step down, and Sarah Beth, I think, is kicking it off.
Good morning. Our journey probably started very similar to how your journey started back in 2015 when the measure set with sepsis came out. Several things that we want to talk about today and share with you, but first, who are we? We're a small facility down in East Central Alabama, and if you're in the Lake Martin area, you're going to go near us. Most importantly, this time of year, if you're traveling to the game on Saturday, you're going to go down 280 from Birmingham, and you're going to pass right by us. There's somebody that goes to Tuscaloosa over here shaking their head. But we are on the way to Auburn, so we're on Highway 280 in Alexander City. 81-bed private facility. A lot goes on, and as you guys know, because many of you are small rural facilities, the standards are the same. It doesn't matter about our size. So we want to share a little bit about our story and how we've gone on this journey. We're still on this journey, and what we are trying to accomplish. In 2015, we chartered a multidisciplinary team, just like many of you did. We pulled a group together and said, we've got a new goal. We've got a new task that we need to tackle. Our goal was early recognition of sepsis first and foremost in the emergency department. So what could we do when the patient walked in the door and presented? I'm sure you had those discussions as well. We developed screening tools that I'm going to share one in just a minute that we've used. And then we were kind of tasked with how do we handle that reflex order on a lactate level? How can we make our IT system work for us and help us meet those times that were so crucial? But our first step that the team looked at was physician engagement. We had to get our physicians on board and our physicians engaged in the process and really get them to feel like they were co-owners with this. It wasn't us versus them. You're going to hear a little bit from Dr. Goldhagen, but it was how can we partner with this and how can we all go to that common goal of we're going to save patients' lives in our community. Communication was key. We were looking at our hospitalist group and our ED group and how we could communicate with them and make sure that they were engaged in the process. But the big piece of it, when we really stepped back, was communicating to the whole organization. You saw that list and you went, wow, that's probably a lot of leaders. It is, but we're small, 81 beds, 600 employees. So there's not a lot of depth. So a lot of people, just like in your organizations, wear quite a few hats. So how do we communicate that down to that entry level, that new employee that's joined us? How do they know what our overall goal is and what's happening? So we went to our quality leadership team and said we need to create accountability. We need someone to hold our feet to the fire, and we want to save lives in our community, and we want this to be important for the board as well. Mr. Ralph Rosen's here today. He's the chairman of our quality leadership team, and as a board member, we made it a leadership priority. So every quarter, our leadership team that's composed of board members and physician leaders are realizing where sepsis is and what we're doing and the level of care we're providing to the community. Quarterly, it also goes on to our governing board, and they keep up with how are we meeting those metrics and how are we achieving our goal. So creating accountability organization-wide was important. And we're going to talk about employees. Employees need to understand that the board realizes this is a priority. You know, when we talk about saving lives in our community, it could be somebody that you go to church with, that you're at the ball field with, that you see at the grocery store. So it was more than just a number. Those were faces that we were able to connect with. The next thing, our team met every 2 weeks, rain or shine, may be a 15-minute meeting, and it may drag on for an hour if we have to get down in the dirt with it. We talked about our overall compliance, and then we just talked about what's working. How's it working? Is it working or not working? Early on, our success was found in allowing our CMO, who was working in the ED, and also our ED manager, just to share success stories. Don't you often wonder as a nurse, does that fluid bolus really work, or are you drowning somebody? So they could tell those stories and say, let me tell you, I visited the patient in ICU or on the med-surg floor, they're alert and talking, they were almost dead. Y'all have those stories? We shared them, and it really energized the team. And in turn, we could share back with our line employees that if we follow protocol, it works, and it works really well. This is just one tool that we used. We created a flow sheet. It's not electronic. We put it on paper first. It's so everyone could see, and you can touch it and make sure you were hitting all the metrics as you went through. Our biggest tool that we've used, though, has been our compliance tracking tool. We call it a missed opportunity report. Yes, it's a retrospective review, but if we fail in some of our measures, it's completed. It's handed back to that leader that's responsible. It's talked about on a monthly basis or on a weekly basis as the team gets together, and it's really a root cause analysis for any area that we failed. Now, these stack up a lot. Don't think we're perfect. We're still a work in progress. But it gives us something very tangible, and it's a way that we can track data and actually quantify that data as we're moving through trying to streamline processes. we still kept looking at we're missing something. Dr. Goldhagen's going to share some of our numbers, but it was like we were missing something. What were we missing as an organization? We use a data analytics vendor, and we stepped back and said, how can we tell our story better? So we came up with this quartile graph that later became our quality dashboard that we implemented. We benchmarked ourselves against the top 100 hospitals in the nation. Yeah, we're small, 81 bed, but we want to be a top 100 because if we do that and if we push towards that goal, we know we'll impact lives in our community, we'll save lives, and that we'll be a better organization. So it gave us a target to run after. We presented this and it quickly became our quality communication scorecard. We call it our scorecard. You ask our employees about it, they can show you, they can talk about the scorecard. So you see the quartile graph, we talk about the dots on the graph, and our goal is how do we move the dots to that upper point? This is a sample, this is not us. This is where we want to be. And how do we move the overall dot to that upper right-hand point in it? Mortality is on here. It's nice to hear Keith earlier this morning talk about mortality. It's like, well, how do you measure sepsis and what do you do? We quickly went from hitting metrics to where are we with mortality? How do our mortality numbers look? And are we saving lives? How are we doing with impacting care in our area? So there's a dot on here that's about mortality. We can drill it down and we can actually look at sepsis mortality. So our employees get to see this on a quarterly basis when it's published. It's posted in all the common areas. They can look at not only where are the dots, are we moving our dots, are they making an impact in the organization and with patient care, and then they can go and drill down and look at these trend line graphs and how does it really look? How does that dot look? And are we making progress? And it gives a little definition so they can actually see, and so we can all see, what does this mean and are we hitting our metrics as we should? We use this as our quality communication tool in the organization. I think the biggest impact is when we make senior leader rounds, our CEO, Jim Peace, pulls that graph out and he waves it to the employees and says, come gather, have you seen your latest numbers? You're doing such a good job. Wow, what are you doing on your unit? And it doesn't matter what unit. On your unit and your department, and this is how you're impacting quality in our little small community and what we're doing for our coworkers and our families and our friends. We do something called birthday meetings. So we talk quality at birthday meetings. If you come to Russell, we are going to put you to sleep with quality. And when we're going to talk about it, the good, the bad, the ugly. And we meet, senior leaders meet monthly if your birthday is in that month, and we talk and share the latest, greatest. And we always do a 5-minute, let's talk about what you and you and you are doing to impact quality in your department. That includes everybody. That's the housekeepers are included. That's our dietary employees are included. Everybody is included in this. It's posted, and then governing board has the same discussion on a quarterly basis. Ralph leads that. They look at the same graph, they look at the same data, and they too talk about what are we doing to impact quality in our community. We feel like we've been a success. We've created that accountability. We all need accountability. So we have that accountability straight to our governing board. We can tell those employees every day, we're accountable to the board. They're holding us accountable. They're looking at what you do. It's very important in the life of our organization is what we do. It's also a great way to engage physicians. They're numbers driven. They can see what's going on and how do we get them engaged and how do we get them involved in what's happening. And it's a great way to communicate those expectations and those results extremely well and very, very clear. Now, there are times when that number goes real high and that dot falls way low. And we talk about that and we share the good, the bad, the ugly, but everyone knows The most fun part, though, is celebrating those achievements. No, we don't go fly flag and do a birthday party and do all this stuff. It's just simply walking in a department with senior leaders, gathering the ED staff around and going, hey, guess what? You now hit this number with your 3-hour bundle compliance. You guys are awesome. Well, at first, they all fainted. Now they're like, what are you going to say about us today? So they enjoy senior leaders coming together and actually recognizing their efforts because they're there every day, every hour. You guys know they work hard and they want that recognition for it. So it's a great way, just a piece of paper, hold it up and go, you are a star because you did a great job. Employees love it. The main thing is, through our sepsis journey, we have learned to become a data-driven organization. So we are looking at that data, we are plotting it out, we are following it and trending it, and we are pushing it down to that newest level employee. They may not get it at first, but over time, we know with repetition, and as we just drone on and on, they'll go, stay away. Here she comes. What is she going to ask now, or what is he going to ask now when Mr. Peace shows up? So thank you for letting us share our successes. I'm going to let Dr. Goldhagen kind of pick it up from here and talk a little bit about the ED side.
Hello. All right, so where we started, I really felt like this was how we were when we first started, when you start looking at mortality. But it's nice to know that this is where we feel like we are now. And a lot of hard work has gone in to get us to this point. Really just want to talk about the CMO's role in meeting some of these metrics. You know, I have a saying, talk is cheap and easy, and you can talk the ears off a dead rabbit with the physicians over and over and over again, but really finding what motivates them and what is effective for change that's permanent change, not just a transient change. So that was one of my things that I did as CMO, was try to find that for these physicians. So there were two separate groups that I targeted, and that was the hospital medicine and the emergency medicine physicians. Now, before we got to that point, we had to lay a foundation. One, I had to get the physicians to understand that it was important to early diagnose sepsis, that we could make an impact, and Sarah Beth talked about those stories that we told. And we had to make sure that they are number driven, that they knew that our early identification of sepsis and our treatment of sepsis did indeed save lives. Then we created something called ED order sepsis sets. You know, in the ED, things get crazy. And there's a whole bunch of different things that have to be ordered to make sure that we fall within the metric. So, you know, when you do trauma, you have ABCs. And it's not that ER physicians aren't intelligent, but we just have these algorithms that we follow because there is so much chaos going on that we just fall to it. So it was important to invent something for the ED physicians that they could just fall back to. It also was important that as a single provider in the ED, if we were busy with another critical patient, the nurse in the ED could initiate them, and we could make sure that we had an early initiation of those orders. But then we also followed through that we found that on the hospitalist side, when they admitted the patients, you know, they were chaotic too. They were getting phone calls and doing different things. And, you know, they might forget one of the metrics, and then, of course, we would fall out. So we sat down together, both HM and myself, and we created these admission order sets. So it was just an easy pre-check. They can uncheck or pre-check, but they'd make sure that we'd include everything in the order set. Also, we found that we had a problem with the reevaluation when a patient came in septic shock. You know, they do the reevaluation. At first we were a little behind on that, but then we finally got to doing it, but then maybe they leave out an element such as like capillary refill, so it would fall out. So we made a template, has all the different things in there. They have to document it all to get through it. So that definitely improved our numbers. Then also, as a CMO, I got involved in the nursing sepsis handoff sheet, which I have to tell you really is the physician sepsis handoff sheet, because we love to find it. We love it being on paper because we can find it, look at it, and make sure that we indeed have done all the things that we need to do. So common characteristics about these two groups. You know, you can talk to them about saving lives, and that is important, and that's what we're all in this to do, is to save lives. But it's almost like alarm fatigue. You talk about saving lives, and then eventually, you know, but they're busy, they have other stuff. But then, so what is it? What is it that is that extra little step with the physicians? And for me, I found that my physicians is competitiveness. we're all competitive. We had to be to get where we are today. But if you can to stimulate that competitiveness between HM and EM, you actually find some really good results. So we posted our 2016 fourth quarter data. So it was our 3-hour and our 6-hour sepsis bundle. So 3-hour obviously is more involved in the ED, and the 6-hour is more involved with hospital medicine. Well, I was very happy to see, of course, that the ED 3-hour window was 91%. I was actually impressed it was that high. I was so excited. And then even though the number is great at 82%, HM was 82%. So we posted this both in the ED offices and the HM offices, and as CMO, I fanned the flames a little bit, and we started talking about it, and we decided that we would let the games begin, and we'd see how it all went. And sure enough, our next quarter data came out, and the winner was HM. So our 3-hour, we went down. We went from 91 to 84%. So the ER physicians got a little overconfident about that. But the HM physicians certainly didn't like being behind, and so they increased up to 88%. Again, still all good numbers. So I fanned the flames again a little bit, decide what we can do in the ED and in the HM program, and our second quarter data came out. Well, you can see who the competitive people are at our facility. The HM went from 88 to 94%. They didn't like being last or second on the first one, and they definitely wanted to drive it home. Even though the ED went up a little bit, 85%, really wasn't back to the original, and the question is why. So Sarah Beth showed you those missed opportunity forms. As the ED director and CMO, and as the HM director on the other side, we sit down with the different physicians, we review those charts, sit down and say, hey, why was this missed? Did you have some concerns about that? And we look at each of them on an individual basis. For us, often it's the fluid resuscitation. People are very nervous about giving 30 mLs per kilo of fluid. So that's something that we've addressed, and we hope that'll improve our 3-hour windows. Also, as CMO, you have to think beyond the walls of just the hospital, or what I say is thinking outside the box. So going a step beyond for sepsis. So I was charged with going out to the different physician offices, and I worked with our physician liaison to talk to them. If they have a patient who they think is in early sepsis in their office, don't direct admit them. We're never going to make that 3-hour bundle upstairs. Send them to the ED. We really promote that the ED is, the primary care physicians are our customers. We are open for business at all times. So don't put them upstairs, send them to the ED, we'll take care of them, we'll make our metrics. It's an opportunity for us to do well and beat the HM next time we have that. I also went to the nursing homes, going out and talking to them. You know, a lot of nursing homes are putting primary advanced care providers in their facility. And certainly they can take care of some of that. But when you recognize that the patient is septic, we'd much rather get them, again, in the ED. Our doors are always open. We're like Walmart, we never close. But we like to see them when they have early sepsis or sepsis. We don't really want to get them when they're in that septic shock stage. So again, early detection. And the last area that I went out and talked to is EMS. You know, they are really integral in setting the tone for treating the patient in the ED. When they call in and tell us that, hey, I think I have a septic patient, that sets the alarm bells off in the ED, and that sets us on that path. How many times has it been that someone says, oh, well, it's chest pain. Well, you think chest pain, you think cardiac. You don't necessarily think that they have pneumonia and have sepsis. EMS has thermometers on the ambulance, so they can certainly take temps. And EMS will pick up patients from transfers, so it's important to have them be your front line, to ask them, have you given antibiotics? Because even though we're transferring from one facility to another and we may not meet that metric, it's still important for the patient. Let's not forget, it's not about the numbers, it is about the patient. It's important to make sure that patient gets those antibiotics before they leave, or that fluid resuscitation, or antipyretics. And then also these EMS people pick people up at the nursing homes, and they also pick them up at home. So again, just getting their frontline report, getting them to think about it, promotes us to think about it and to address it and initiate the sepsis protocol early. And that's all.
Let's see, I'm going to start up here and see how that goes. Hey, I'm Bill Meckes, general surgeon. I am trying to retire. And Rosemary's given me the worst talk possible, how to make doctors hold hands and act right. But we don't have any problem with that in Muscle Shoals because we're right in the corner of the state, up in Sheffield, Alabama, and it's cooler up there. And every morning, everybody comes together, and we hold hands and sing Kumbaya. No, we got the same grumpy, frustrated, burnout doctors you got, right? And so I want to show you what's happened at Keller Hospital so you can see, not brag about us, that you can do this too. And so you see the size of our hospital. It's not a huge hospital, 163. I think we're running 130 right now. If you stratify the hospitals in America, there's about 5,500 hospitals, and about 4,000 of those are under 200 beds. And so one of the things we want to share with you, we don't have an ICU doctor that's full-time. We want to show you our data that we produce through protocols that we can improve survival in the sepsis realm. And so if we can do it, you can do it. We have the same grumpy doctors. We have the same I'm broke problem that everybody else does. So let's look at what we've got. So background, we began our journey in 2012. We got that stuff from Blue Cross. Y'all don't have a sepsis protocol. So we began to do that in 2012. And so we brought in some outside education to try to help us. And that was my son-in-law, Chris Thomas, and he's down at Our Lady of the Lakes in Baton Rouge. He's on staff down there. He's been up 2 or 3 times to facilitate this project, and really he's the brains. I'm the general surgeon. He's the brains behind the outfit. And so he's come up and helped us, and we brought him in 2012. It took an expenditure of the hospital. We looked at the Survive Sepsis campaign data, and we said, this data's good. Our data's not as good as this. How can we make this a PI initiative? So before we got it crammed down our throat by the core measures, we started this in 2012. And so from 2012 to 2014, honestly, we just struggled with this process. It is very hard to get doctors on board. And so our mistakes can be your benefit. And so we worked on it. We finally had 2 events that occurred in our hospital after we floundered around for 2 years. The first one was we had a moral crisis. And so we brought a guy in to teach us, and we looked at the Survive Sepsis campaign data, and we presented that data about survival rates. And all of a sudden, we have a patient that comes in during this time frame, and this is kind of a hypothetical patient, but here's what it is. It happens all the time at a lot of hospitals. I don't go any place that somebody doesn't tell me after I do a sepsis talk. I'll have somebody come up and cry, and they'll say, my mother, my father had sepsis. They never recognized it, and they died. This is a patient that came into our institution, flank pain, left, came back in 3 days later. You can see how many SIRS does he have. There's 2 right there, 3 right there. He has organ failure, creatinine 3.6, blood pressure 82. He's got multi-organ failure. What's the diagnosis? He's septic. Came in the hospital. We did not do source control well. He laid on the floor. Y'all know we have to do source control within 12 to 24 hours, right? The American College is 12 hours. Survive Sepsis campaign is 24 hours. We have to have source control in this patient population. Came in critically ill, consult, had an infection in his skin, subcutaneous skin infection, and you see what happened to him. And so basically this chart came after we had instruction from an outside source that we spent money for, and we threw this chart at MEC. I took it into MEC and go, is this okay? We either A, have to transfer this patient, B, we have to take better care, but this patient laying in our hospital is not okay, right? That's not okay. And so we had to learn the hard way. And so in 2014, the tires were still spinning. So I brought in, we volunteer for transforming healthcare, reducing sepsis mortality. So some of the protocols that are activated within our systems today are based on this pilot that we were involved in 2014 to 2015. We were the second cohort of 5 hospitals. And so you can see the other hospitals that are in that. We participated in that for a year, and we started getting traction in this process. And we started growing, and we started implementing these processes. I will let you know that Helen Keller from Alabama, look at the other places, we beat them all. We were better than every one of them. How about that? Oh, and look at this. Look at this. Now I am going to brag right here. We got this thing going, United States with sepsis certification. Do you see Helen Keller Hospital is the only hospital in Alabama that has a disease-specific certification? Is that awesome or what? Y'all can do that. It's nothing special. What does my doctor's parking lot look like? It's pickup trucks. Right? It's not Ferraris. It's pickup trucks. Do y'all have pickup trucks in your doctor's? Okay, if we can do it, you can do it. So we're very excited and proud about this, and that's why we're here. We want to share our results with you. And really, here's the deal. Why can I stand up and talk in front of you? Look at the national average. The national average of death related to sepsis is 30 to 50%. That's above the line. And in 2012, we started out around 23%, and if you average those 4 years, we were at about a 20% mortality rate, which is better than the national average where we started. But look at our mortality rate in 15, 16, and 17. We have had a reduction in mortality rate by 50% at our institution. That's awesome. Y'all can do that. If we can do it, you can do it. Look at this data here. Dr. Chappell, I want you to look at this data. See, we've got Dr. Chappell, he's the CMO of all the health system of Huntsville. I want you to look at that green line. That green line is the number of days reduced for every sepsis admission. We have reduced the length of stay by 2 days in that patient population. This is one of the few protocols that I have ever seen that cost less and save lives. And so you see, what is our mortality reduction? It's huge. We continue to have a reduction in mortality rate. And so we kind of stratify, and we talk about reduction in mortality rate, and we also talk about lives saved. And I'll show you that just in a minute. I just got off the phone with a fellow up in Cullman, Dr. Smith. He's part of the Huntsville system, and I asked him what his mortality rate reduction was this last year. They saved 50 lives in 2016. 50 lives. We went in and talked with them. You know what they did? They did a radical thing at Cullman. They made my talk mandatory for every physician on staff. Oh yeah, they fought and carried on. Who gives a rip? Y'all don't care, do you? And so somebody somewhere has to get some gumption and say, every physician in this facility is going to be trained on sepsis. Why? Because it's the #1 killer in our hospital. We got to quit being namby-pamby about this. If you say, oh, the opiate epidemic is terrible. Yeah, I Googled it while I was back there. How many deaths in the opiate epidemic last year? 50,000. How many in sepsis? 250,000. 1 every 2 minutes. Surely we're going to have to get serious about this. And so that's part of the thing we're coming here to challenge you to get serious about it. And here's what we don't want. I don't want the docs forced in. And so I got this bad talk. I got to figure out some way to get doctors on board. How do you get the doctors on board? That's the problem, right? They're checking the boxes, but they're mad at you about it. They don't want to do it, and they're grumpy. One more box to check. They really don't give a rip. And so that's not the way to get them on board. So how do we get them on board? How do we make them have ownership? You have to stratify your data in your institution. And until you show the doctors that you have a problem in your institution, they will not engage with you. And that's going to require some work. And so what did we do when we came in the Healthcare for Transforming Medicine? We stratified our data 4 years prior to the event where we started, so we knew what our mortality rate was and what that mortality rate was related to the national average. So if the doctor does not know there's a problem, you are not going to engage him. Y'all know that we're problem solvers, right? And so what you have to do is you got to say, hey, doc, this is the #1 killer. If you're in a non-cardiac hospital, sepsis is the #1 death rate. It may not be coded out right yet, but it is the #1 death rate in your institution if you're non-cardiac. It is in ours. And so it kills more than breast cancer and heart disease put together. 2016, 12 to 16, it is the #1 killer at Helen Keller Hospital. So here's what you got to do. You got to get that data. And you've got to present that data to a core of doctors, and you've got to get them interested in helping you solve a problem. If your data's bad, you need to engage them to solve your problem. And so you know who they are, right? Y'all know who the guys are that are interested in it. The guys or the gals who are interested in it. So gather this data together and show them the data. If you need some help trying to figure out the data, we've got 5 CPT codes. How we gathered our data, you can get the same CPT codes we used. And you can gather your data so you can present it. Until you do this, your doctors won't engage. There'll be a have to instead of a want to. And so we did this, and we taught it everywhere. The hospital must be invested in this. We spent money. We brought outside instruction in. We pay employees to take time off to receive sepsis education. We pay them. Why? It's one of our PI initiatives. You know, here's part of the problem. We gripe about the government telling us what to do with a core measure for sepsis, don't we? You know why we shouldn't be griping? We should have already done it, right? We don't need the government telling us what to do. We should have looked at the Survive Sepsis campaign data that's come out since 2002, 2008, 2012, and again in 2016. That is good data, and it is solid data. It's good evidence-based data. And we got the same problem in our hospital that you got. I don't believe in evidence-based data, right? Is that what your doctors say? Really? Well, what do you believe in? Witchcraft? I mean, seriously. And then they go, yeah, you remember when Medicare told us we had 6 hours to read the x-ray and give antibiotics in that pneumonia protocol? Remember? They changed it. Well, good grief, we change medicine all the time, right? That's part of the Hippocratic Oath, that as I get new information, I change it and readapt information. And I heard the other guy saying, I don't like change. Well, get over it. You're not going to be a good clinician if you don't like change. It's part of the process. So we've got champions, that's 900 clinicians, mid-levels, and nurse practitioners. That's in our last series prior to our Joint Commission survey. So we're crazy enough, we had Joint Commission come in without forcing us. We had them come in to assess us on our sepsis training to get certified. That guy said this is the best hospital he's ever seen for physician engagement. And it comes about by presenting the problem to the physician and saying, hey, doc, can you help me get to best practice? We're trying to get to best practice, right? You have to engage him in that process. So moving towards best practice, there's a definition. We know what it is. It's a procedure that optimizes results. It's established. It's good medicine. And it reduces mortality rate in your hospital. And here's what you don't say. Hey, doc, I need you to help me with these sepsis orders because the Joint Commission wants us to do that. How's that work? Okay, well, don't do that. Don't do that. Here's what we need to do. That's me. That's Dr. Chappell when we used to practice medicine. You know, I was the last stronghold for sign, date, and time. It was awesome. I had surgery in 2009, and I told them, I said, I will never do that. I didn't know I was going to have surgery and not be able to go back and operate. Sign, date, and time. This is what your doctors are. They're mad all the time. So how about this? Hey, doc, could you help move the hospital to best practice for sepsis? The core measures actually inculcate the best practices, right? They are behind the best practice. And so when we say, whoo, I'm excited, we've got the core measures going, you know you're still behind. The core measures are the minimum. They're not the best practice standards. Would you consider helping us with the sepsis orders? And this is one of the things we did. All of our sepsis orders back in 2012 through 2014 and 15, way before CORS came, they went to MEC. The MEC approved of these orders, and they became a standard in our hospital. I don't want to do that. Well, good. Would you like to meet with MEC with me? And so there's some sweating, institutional sweating, when you take a line and you take a stand. Do you have to keep up? You have to keep up. Yes, do we do diligent? We meet every 2 weeks. Our sepsis task force meets every 2 weeks, and we're fixing and tweaking processes that are broken. It's an ongoing process. New employees about every month we re-educate. Dr. Carmichael just re-educated. He just went to the nursing home and re-educated. We just had a lunch and learn, educated. Had 80 people there last week and probably another 80 this week. And we do something sneaky. We got that sepsis screening tool, and so we give it out to all the old people. And when you do a talk to the old people, you have to say this first. Look, I've looked in this room, and nobody in this room has sepsis. Everybody's okay, because they're all thinking, I think I'm septic. And then we do this other mean thing. I say, look here. I'm going to give you a sepsis screening tool to take home. Really? Yeah. And here's the deal. You can look and see if your heart rate's getting real high and you got an infection, you think you're infected, your urine gets real dark. I give them some clues how to go there. And I said, I want you to take this sepsis tool, and then I want you to go ask your doctor when you go in his office, say, hey, doc, you think I'm septic? But do not use my name. Please, do not use my name. Don't use my name. So we're having fun with sepsis, right? Did y'all go into medicine to have fun or what? Just don't be grumpy about it. We got the best job in the world helping people. And then, yeah, we do have some yucky stuff here. Here it is. Violations. You're going to have some violations. You know, as we inculcated the sepsis protocol into our VP and OP, this became a checkoff list, and if you miss 3 sepsis bundles, guess where you go at our hospital? You go to the quality council or you go to peer. Why? Because we're serious about taking care of this population of people. Does it make everybody mad? Yeah, but we've overcome it. We've overcome it, and now we've got enough people on a quality council that's multi-specialty, and we begin in showing these charts, and you know what they say? You need to get that doctor to come up and talk to us. I'm going, yes. See, now it's not an administrative project, it's a physician-driven project. That's what you got to do. You got to transition this from administrative. The administrative limb really needs to try to stay under the radar, because if the administration pushes it, it aggravates the doctors, right? Y'all know that. Okay. So we've done educational letters. How many educational letters did you send out last week? We send out about 5 or 10 every 2 weeks. If you miss a bundle, we look at every bundle miss. Every bundle miss. We look at every mortality. We do a mini root cause analysis on every bundle miss and every death in sepsis in our hospital. That's a lot of work. Did you see our reduction in mortality by 50%? Yes, a lot of work. That's what we went into medicine for, right? To work hard for the patient and take care of them and be diligent. FEPI, we've had one FEPI for cause. That was really ugly. This doc had a patient. The patient was sick. He didn't take good care of the patient. He had to come in to peer review. It was really, everybody got sweaty on that. You know how that goes. And guess what? He got 100% review. He went into FEPI for cause. Y'all know about FEPI for cause, right? Have y'all done that on anybody? A few times. We did a FEPI for cause on sepsis. Got everybody in the institution tense. It's okay to have some institutional tension, right? Makes people perform better. And so they hear about it, the doctors hear about it, and they go, ooh, I better look at those bundles. I better look at that. I don't want to be up at peer. They don't want to be at peer. You know, when they come in and sit in the administrative office before they come into peer, you know what they look like? They look like a little kid getting ready to go see the principal. They're not like they're acting out up on the floor, right? Because they respond to their peers. And this is hard. I'm not telling you this isn't hard. It is. Do the same thing for the nurses. You got a nurse that doesn't screen in the ER, she's gonna come up, she's gonna end up at quality council. I hate it for you. Accountability, they talked about it. If you do not close the loop with accountability, what's my time? Who's helping me? You are. I'm okay? Here's our Hippocratic Oath. I swear, I can't hardly see that. I swear to fulfill the following, avoiding these 2 twin traps of overtreatment and therapeutic nihilism. I'd look up that nihilism. You know what that means? It means I don't believe in the new therapeutic standards. It's just a negative, pessimistic person. Y'all don't have any of those, do you? I don't believe in them sepsis protocols. Well, then you can take our data and you can show it to them. You say, hey, doc, this is a small hospital that runs 100 people in their hospital. They've reduced their sepsis mortality by 50%. That is huge. That's one of the best numbers in the nation. And we've done that in a small hospital without intensive care doctors. We've protocolized this process through the ER. We're catching them from the doctor's offices. We're doing the same thing. We're funneling them into the ER. We're going to the nursing homes, and we're educating the nursing homes. This is a full court press. There's 250,000 people that die from this each year. We've made a promise to stay up to date. We've made a promise to be open-minded, and we've made a promise to pass along information one to another in things that help patient care. Sepsis is now a core measure. It's the increased expectations of it. Look, I hate to show you this slide, but I'm forced to show you the next slide. I did take the name off of it to protect the guilty. Do not go to the internet and look at all the advertisements. If you've had a loved one who's recently died from infection, we are here to defend you. If we cannot stimulate you with the Dr. Chappell's carrot, well, then we have to use Dr. Chappell's stick. And this is the stick. This is a terrible way to stimulate physicians. We have to stimulate them with a want to do this because we see a production of lives saved. But this is what's going to happen right here. They're going to be in a lawsuit. The institution's going to be in a lawsuit with it. So how do we stay on the positive side? Here's patients saved. So we got 36 in 15, and we got 40, and we're about 30 this year. So we keep that positive. This is how many patients. How did we do it? We stratified the data. We looked at the 3 years before without the sepsis protocols. Then we looked at the 3 years after that. We just stratified the data. Is it hard work? Yeah, what do? We don't just pat them on the back, we feed them. You know, in the South, we feed people. So we have we had a recent, did we do that party yet? Last Thursday. We had a pizza party and cake, and we showed our data, and we bragged about them all and pat them on the back and gave them just a little bit back for all their good work and diligence. So what's the cost? It's yucky. This is the worst thing. I would much rather put you to sleep and cut you open than do this. This was the hardest thing I've ever done. It's hard to move people who don't want to be moved. This is a very hard project. It takes financial investment, discipline, it causes you to sweat, makes people nervous, but what's the payoff? There he is, right there. That's a guy in our community that just helped us with a video. He's one of 108 people who survived sepsis. And we got a little band we put on you. Helen Keller, sepsis survivor. Is that awesome or what? You know, when you do something good to somebody, you know how many people they tell? About 4. If you do something bad to somebody, you know how many they tell? About 9. This guy's telling everybody in the county what a good place it is to come to Helen Keller. And we're going to have an ad up. When minutes count, you can come to Helen Keller. We have certified, we have a team standing by. And that puts the onus on us, right? We got to have the protocol, and we got to be set up, and we got to be diligent to look after these things. Okay, I was asked by Rosemary to give you this insight on how you treat renal patients and heart failure patients. Y'all know that's the problem, right? You treat the renal patient and the heart failure patient exactly the same way. The same way. Well, I might overload him. Here's the article. You can read this article. This is an article that says the Survive Sepsis campaign. You can go and look it up. The Survive Sepsis campaign does not drown people by treating people with heart failure with fluid resuscitation. It does not drown them. We have been doing this since 2012. We have not drowned anybody. We've looked at every mortality rate in our institution. How do you treat them? The same way. You give them a bolus of fluid. That's the problem. Give it over 3 hours if you have to. It's okay. Renal failure patient. We had a renal failure patient that's died over the past 5 years, and I still wonder to this very day if the fluid resuscitation that was withheld because he's a renal failure patient would not have saved his life. I have no idea. Even though their weight is big, they've leaked it out, right? It's not in their bloodstream. It's not in their intravascular space. They are intravascular. They dry. So is the heart failure patient. The pathophysiology of sepsis is leaky membranes, vasodilatation. They have third space fluid. So if you see the Starling curve, fluids are only bad if the heart is already on overload. You need fluids if you're dry. And we've got this new thing up in Northwest Alabama. We can actually do a test on you and see if you're dry. Y'all may not have it at your hospital. It's called a physical exam. Dadgummit. I can see a neck vein standing up. If you got heart failure and your neck vein's not standing up, you're not wet, right? You can do a leg lift. Dr. Chappell, you still remember a leg lift? He does. You can lift their legs. If they're tachycardic and you lift both their legs up and their heart rate goes down, they're dry. You can listen for basilar rouse, right? JVD, heart murmur. You can listen to those things. And they say, we don't know how to do that. Well, do a physical exam. You can tell whether they're dry, and then give them the fluids. You won't hurt them. We haven't drowned anybody yet. Now, this best practice, here's how the psyche of a doctor works. Do no harm, right? Okay, so here's me practicing medicine. Well, it's easier for me to defend not giving fluids than to give too much fluids and drown them. Y'all know that's how my brain works. And so we have to overcome that. It's easier for me to defend my position by not giving fluids than defend my position if I volume overload them and they go on the ventilator and they die. So we have to teach these doctors to withhold fluids is withholding standard of care. We have to teach them that. And until you do it, until they get a success at it, until somebody holds their hand and they go, wow, that didn't hurt that patient. I had a patient came in a couple of weeks ago that I knew, and I went to the hospital. He had acute pancreatitis. The pancreatic patient is identical to the sepsis patient. They're identical. Why? SIRS is activated in that patient. That patient is profoundly dry. And we resuscitated that patient who had severe pancreatitis with the same fluid protocol that we do in sepsis, and he looked 100% better in 6 hours. I was blown away with how good he looked. Have y'all seen the results of giving adequate fluid resuscitation in that patient, usually who is sick for days and days, and you walk in the next day and you go, God, he looks pretty good. He was really sick. We had one of our ENT surgeons on staff, and he had a prostate biopsy on Wednesday, and he came in with 5 organ failure on Friday night. Thank goodness we had the protocol in place. He went home in 72 hours. He had 5 organ failures when he was admitted. And so we had the protocols in place and we rescued him. Now this is kind of a breakout slide. I don't mean to talk over this. This is something you can have. This is one of the breakout slides that we have as we've grown in this process for 5 years. You can look at a CMP and see if the patient's sick by the anion gap. And nobody in the hospital knows what the anion gap. The anion gap follows the lactic acid. So you can get a quick look. You can get a quick look at the status of the patient with the anion gap. Where the anion gap goes, the lactic acid. The lactic acid is just a cheat test for the anion gap. Also, when we first started this process in 12, we began to overtreat. And so we use lactic acid as an indicator for patients who are septic, right? But the problem is they get crazy and see a lactic acid and think they're septic without checking the box, infection or suspected infection, right? And so you overreact. And so then you got to come back. And here's how we taught them that. Look, doc, lactic acid can be stimulated by a variety of things. It's not just sepsis. It can be pancreatitis. It can be a heart attack. And so we have to make sure it's infection or suspected infection before we do the protocol for that. So this is just part of the learning curve. This was a good breakout slide for us that helped us. Here's one of our breakout slides of accountability, and she's clarified it real well. And you can see down in the bottom, you can see right here, this is where we had a huge breakthrough. The nurse passing off the patient from the ER to the ICU, or the ER to the OR, had to sign this. Now I know who's doing what. That heightened our accountability in this process. Now I can look and see, ooh, we had blood pressure low for 2 hours and nobody got a notification to the MD, and nobody got any fluids, and nobody got any vasopressors and their names on it, right? That's accountability, and you have to have that in your structure. Oh, let me show you one thing. This is radical right here. We had to take this to MEC. If you have a patient in septic shock, who is that? Tell me who that patient is. I have a patient in septic shock. Who is that patient? Who can describe it? Okay, I will. Patient came in with infection or suspected infection. They had a blood pressure less than 90, right? And you gave them an adequate fluid bolus, and they remained hypotensive, and you began vasopressors as well as continuation of IV fluids. That patient, by definition, is in septic shock, right? Now all the medicine doctors want me to come in and see a gunshot wound in an hour. This took me a year to get this through. If you've got a patient in the hospital who's in septic shock, you best come out and see him, right? So now we have that. If you've got a patient in septic shock, you got to come see him. You got to come see him so you can see what he needs. Okay, there you go. Questions? Questions, ask the girls first.
My question is, I see that you have paper protocols. Is any of your processes electronic?
Dr. Heckes, they were asking that you had the paper documents that you provided up there, and wondering if you had it electronic.
Yes, we do. That takes 2 years. I don't know why it takes so long. We fought it for 2 years. Finally, we got it. You can't get through the ER till you check the first box. Infection or suspected infection? No, you can come out of that screen. Yes, but it was a fight. Everything in this is a fight.
Right.
Dr. Meckes, do you have your microphone cut on? You may have to cut the on switch on.
Yeah. We'll pass it back and forth.
Okay.
Okay. Was another question out there? Now that you put the mic on, they don't want to ask you. They're afraid they might hit. No.
Y'all got
Any
here's
further
the deal.
questions?
Part of this is we share results, right? Have you got a good save? Who wants to share a good save? That stimulates medical people. When you tell me about a good save, what is that? They're doing competition. And so when we get together, we ought to go, man, here's how we got this patient the other day. Normally,
I tell you, I had one, and that's what really convinced me. You know, as CMO and the sepsis initiative, and I know this as a physician, but I was actually working in the ED, and I had a gentleman who was in the room that I went in to see, and he was frail and old, and his wife is there, and obviously I think he's early sepsis. But I went ahead, it's protocol. This was in the early stages of us doing this, and I initiated the fluids and gave him antibiotics, and I did everything by the book and put him in, and he had low blood pressure. I put him upstairs in the ICU, but I was interested to see what he looked like, and see how he was doing the next day. So if I had been a better physician, I might have taken a better social history, because when I went upstairs to the ICU, this gentleman that I did not recognize at all is sitting up going, yeah, I was playing tennis 2 days ago, and I was playing golf, and he plays 18 holes of golf. I mean, this was not the frail gentleman that I saw there, and I made an assumption. That just one of those, I knew he wasn't from the nursing home, but I knew he was from home. But I honestly did not recognize the man when I came in, and that motivated me. And that drove me to really believe in it. And I challenge each one of our physicians on the staff also to talk about theirs as you do. And we've all had them, and we do share them. And it does really help.
Other questions? Rosemary has identified one. Okay.
It's not really a question, but the takeaway from here, because we have been to education, those on the team, sepsis education, but share those stories. Let's take it back to the ED, 12 hours, 24 hours later, the ones that we have that do really well, because I don't think we do a good enough job at our facility sharing that. And that was my takeaway today, was that'll be the number one thing I go back as a project for our team to institute that right there, because I think that'll make the biggest difference.
yeah, go back and visit the next day.
My takeaway is I want the bands. I think that is a really unique idea.
Okay. Good feedback. Thank you, Darla. Other questions?
I have one, I'm sorry.
Okay.
Dr. Meckle, I know you're going to be talking to our physicians in a couple of weeks, a couple of Mondays, I think. What should we have prepared for your presentation?
If you can stratify your data, if you can get your institutional data about your sepsis mortality, is it the number one killer, the number two killer, and then look at the total number of sepsis admissions to the death rate. Misty can help you figure out how to do that data. What kind of computer system do you have? Okay. That's what we got now, isn't it? What do we got? You got to get the data to them. They're problem solvers, and if they don't see it as a problem, you're not going to engage them in a robust way. You're just not. It's going to be a have to, and they're going to be mad at you.
Question over here. Let us get the microphone to you, please.
You mentioned the 5 DRG codes that y'all use for, can you share that?
Yeah, you can with Misty.
Okay.
Helen Keller. That was the 2014 5 CPT codes that we were required to do to stratify our data. Now, I don't know if we're stratifying our data based on those 5 CPT codes, but she knows. Misty, did you want to talk about that? No, they don't want me to call. Yeah, come get her when we're done and we'll help you.
We'll be taking a lunch break shortly, so don't get lost. Okay. Other questions? Okay. Well, thank y'all, panelists. Let me just say to each of you, today is a perfect example of why we want to have panels at these events. I found this information just incredibly helpful. It's great stories. I can't imagine working in one of your institutions and not be enthused about the possibilities. And I'm telling you, we said it early this morning, we're saying it again now. Each of you can do what you heard described here, and we have the opportunity to save lives. There are people dying in your communities because we're not instituting these processes and procedures and educating and giving our physicians the opportunity to help us save these lives. And I really want to encourage you to make a difference in this area, because it is one of the fastest, it's not easy, but it is one of the fastest ways to save lives in your organization. I have a number of announcements. Let me run through them very quickly, and then we'll get to lunch. Reminder, BD MedMind is having a luncheon for its customers, and we'd invite you to go to Ballroom 3. All others who are not MedMind BD customers, you pick your lunch up, come back and eat at the table that you have in this room. If you are leaving for some reason, please check with the desk to get your swiping of your nursing card so that you can get CMEs. You'd get a half a day's credit if you leave at this point. If you want a full day, stay with us, have lunch, and come back. And also pick up your discounted parking pass at the desk if you'd like to do that. And otherwise, our program will resume at 1 o'clock. We've had a great morning. We think we'll have the same this afternoon. So enjoy your lunch. Be back ready to go at 1 o'clock. Thank you.